Welcome everybody, and we are so grateful to have you come here for this. VOA and the Centera Cancer Network are hoping to engage everybody in the community from a bunch of different subspecialties and a bunch of different disciplines in immuno-oncology, which is one of the best things that's ever happened to cancer care, if you want my opinion. You know, it has made untreatable diseases somewhat treatable. It's given late-stage patients hope for something that when there was none, but it comes with a different set of toxicities, and if they're not managed well, that they can go bad. Not only that, they can occur late. So if you are a primary care physician or an APP in a primary care, and you're seeing our patients, it can be months to years after we've seen them when you may actually see some of the side effects occur. So we are trying to invite the community at large to help us in the management of these patients. The drugs are tremendously promising, but early detection of toxicity and something going bad is important, and we'd like as much help at that as we can possibly get. Tonight, we've asked Dr. George, and many of you, maybe most of you in the room probably know Dr. George. Dr. George is one of the founding members of Virginia Oncology Associates, and I'll give you his background. He's Associate Professor of Medicine at EVMS, and he is obviously still a hematology oncologist with Virginia Oncology Associates here. He attended the University of Miami Miller School of Medicine, did residency in internal medicine at Columbia Presbyterian, and served as a clinical associate in National Institute on Aging of the NIH. He completed his fellowship in hematology and medical oncology at Duke University, was chairman of the National Policy Board for the U.S. Oncology Network, former president of Cancer Centers of Virginia. He's board certified in both hematology and medical oncology, and a member of ASCO, ASH, and AOA. He's been a lot of places, and a lot of people know him. Everywhere I go, people know Ed. This is my favorite part about what he gave me about himself, though. He resides primarily in Virginia Beach. Above all, Dr. George is blessed with Karen, 3 wonderful daughters, 2 loving sons-in-law, and 5 beautiful grandchildren, who are his most cherished interests. For tonight, one of his interests is immune checkpoint inhibitors and immuno-oncology, and we look forward to hearing him present. Thank you, and thank you for being here.
Thank you very much, Nikki. You read that exactly as my mother wrote it. Tonight, we will talk about checkpoint inhibitor cancer immunotherapy, and we're going to talk about the mechanism of action of the efficacy, the mechanism of the toxicities, and the management, and how we control the toxicities to engage as much response and efficacy as possible. Immunotherapy broadly is the treatment of disease by either activating or suppressing the immune system. It has become the 4th pillar of oncology care. The first 3 pillars, of course, are surgery, chemotherapy, and radiation, and now immuno-oncology has become the most important recent development in the field, as Nikki said. We can divide immunotherapy into different categories. We can look at activation immunotherapy, such as vaccines, Sepulusal T, GP100, some of the single and multiple peptide vaccines, oncolytic viruses like the herpes virus, which can be injected into tumors and produces a TVEC type vaccine, cytokines, IL-2, interferon, GM-CSF, tumor necrosis factor, T-cell manipulations, CAR-T, ex vivo expansion of tumor infiltrating lymphocytes, and monoclonal T-cell receptor therapy, and then checkpoint inhibitors, which really are what we're going to concentrate on this evening. Now, in terms of the other branch of immunotherapy, there's suppression of the immune system, steroids, of course, as you well know, affecting both B and T cell function, purine analogs and alkylating agents as chemotherapy agents with cytotoxic effects, calcineurin inhibitors, very important in terms of suppressing graft versus host disease in transplant settings, anti-tumor necrosis agents, and interleukin antagonists. These you will see advertised on television constantly. Cosentyx, Entyvio, Remicade, and so forth. These are the kinds of things that are considered suppression immunotherapy. Why is immunotherapy important? Well, until immunotherapy began to change the landscape, some of the results with major tumors were very, very poor. For instance, the 5-year survival in advanced cancers that was assessed in 2015 with SEER data showed that lung cancer had only a 4% 5-year survivorship, colorectal only about 13, renal, urothelial about 12, melanoma 16, and bladder about 5.5%. So the 5-year survivorship for many patients with these tumors until the development of effective immunotherapy has been very poor. And it was estimated that in 2016 there were almost 600,000 deaths due to cancer. There is an unmet need that immunotherapy is beginning to supply. You can also look at immunotherapy in another way, that is passive or active immunotherapy. Passive therapy is designed, for instance, to act directly on the tumor. Herceptin, the Vectibix, rituximab, cetuximab. These directly affect tumor, often utilizing complement in the process. Adoptive cell therapies, we talked about those with tumor-infiltrating lymphocytes as well as CAR T. And then active, designed to act on the immune system itself, cytokines, the interleukins and interferons, which drive the immune system and are derived from the immune system. Therapeutic vaccines we mentioned, and immunotherapies. This is the area we're going to concentrate on this evening. And we'll talk about checkpoint inhibitors in particular. We'll also be mentioning co-stimulatory agonists, which work in concert with the checkpoint inhibitors. Just a comment about the immune system itself. This basically is a model of how things happen in the immune system. There's immediate responses right after exposure, for instance, infection, let's say, and there is a slow adaptive response of the immune system that can be humoral as well as cellular. In the innate immune system, there are several actors that can immediately respond to the challenges. And these can be mast cells, dendritic cells, which process antigens, macrophages, natural killer cells, granulocytes of all types, and of course the complement system, which is always active, especially through the alternative pathway. And then there's a little bit of overlap with gamma delta T cells and natural killer T cells, which have crossover characteristics with the natural killer cells. And then the adaptive side, meaning you expose a patient to an antigen and that patient's immune system develops a response to it. That has to develop over time, not immediate. It's not phylogenetically ancient so that it's there in the first place and simply needs to be exposed to the stimulant. So B cells, which produce antibodies, and T cells, which actually work to do two things. One, actively process invaders themselves through a specific cytokines and molecules, but also work on the B cell side of the equation as well, stimulating the formation of antibodies. And we'll talk a little bit more about the T cells very shortly. The checkpoint inhibitor story is very interesting. And as you may know, Jim Allison and his co-worker from Japan won the Nobel Prize for the discovery of CTLA-4 and then allowed it to move into the mainstream as therapy. And I think our Bristol colleagues were the ones that marketed that and have made it a great success. So tumors. Tumors, natural tissue that has gone bad. It's mutated. And what happens as a result of mutation, it develops neoantigens, antigens that are recognized by dendritic cells as foreign to the body. The dendritic cell then processes these neoantigens, puts them on a major histocompatibility complex to deliver them to T cells so that T cells can be educated about these neoantigens in order to be empowered to go fight them and knock them out. And nothing in nature happens on its own. There always has to be checks and balances. And so, in addition to that, you have a stimulatory checkpoint, the B7 CD28 combination, for instance. This is part of a superfamily of molecules that are within the stimulatory checkpoints, which we're not going to talk about tonight. We're just talking about inhibitory checkpoints. There's at least 20 different checkpoints that we know of, And we're only going to be dealing with basically 2. And that's all we have medicines for at this point. The future will probably deliver quite a few more. So what happens then is this antigen processing cell teaches the lymphocyte in the lymph node to recognize this antigen, because it comes from a resting state to activation when it sees this process and is co-stimulated. And then it begins to clonally expand and then find the originator of the neoantigen and attack it. Once it recognizes it, if it's not inhibited, it will then release substances, perforins, which basically drill holes in tumor cells, granzymes, which are proteinases that actually destroy cells and prompt apoptosis, and then other cytokines, all of which are designed to damage the tumor cell, including tumor necrosis factor and gamma interferons. So this is the methodology by which we are going to engage checkpoints. The 2 checkpoints that we deal with in oncology at this point are CTLA-4 and the PD-1, PD-L1 combination. This is a lymph node, and this represents a cell that is processing an antigen. It finds an antigen, it processes it, it teaches the lymphocyte through a T cell receptor that this antigen is bad news and it's got to go. And it has this co-stimulatory effect so that it's permitted to do the engagement. But also at this level, there is an inhibitory capability as well. B7, which normally permits activity and activation when it binds to CD28, B7 binding to CTLA-4 will actually shut this lymphocyte off. And this lymphocyte will no longer be interested in going after this antigen. CTLA-4, the drug that we currently have for it is ipilimumab and tremelimumab as well, which hasn't yet been released for mesothelioma, but looks like it's on its way for that. The T cell then migrates to the peripheral tissue where the tumor is located, and it finds that antigen, okay? So here's the T cell now in the periphery, looking for the tumor cell, which is here, finds the antigen and says, you are gonna die. But the tumor cell is smarter than that. The tumor cell actually produces a ligand that can bind with this peripheral checkpoint called program death 1. And when it does bind with that, it can also shut this lymphocyte off because it's a brake on the system. In order to make these things work, the pharmaceutical aspect of this is to block the off switch. So the off switch can't be activated to turn the lymphocyte off. So ipilimumab binds to CTLA-4 to prevent this B7 CTLA-4 interaction, and the PD-1 and PD-L1 drugs bind either to the receptor or to the ligand. The PD-1 drugs that we have are cemiplimab, nivolumab, and pembrolizumab, and the anti-PD-L1, which basically still gets in the way of that interaction, are atezolizumab, avelumab, and durvalumab. So that's basically the mechanism by which checkpoint inhibition does its job and basically can have its job interrupted by a therapeutical agent. This is the site of the tumor, and here you have that activated T cell that has found on the tumor cell the antigen. And if that tumor cell can produce PD-L1 or PD-L2, it can bind to program death 1 receptor, shut this lymphocyte off, and send it away. But if you bind to PD-L1 with an anti-PD-L1 monoclonal antibody, which is a therapeutic antibody, such as atezolizumab, or if you bind to the program death receptor with an anti-PD-1 monoclonal antibody, such as Opdivo or Keytruda, then you basically shut off the off switch so that the activated lymphocyte isn't turned away and now can release the cytokines and perforins and interferons and so forth that can damage this tumor cell, break it up, drill holes in its membrane, and induce apoptosis. Do these things work? It's a very complicated issue, but the answer in short is quite yes. This is a study of overall survival in metastatic melanoma in clinical trials that were accrued pretty much in the pre-checkpoint inhibitor era. And look at this survival curve. This is terrible, over 3 years. And this is from 42 phase 2 trials of patients with stage 4 melanoma, over 2,000 patients. And look what happens here. This is Georgina Long writing in Lancet Oncology in 2017 on 153 patients treated with reduced dose ipilimumab along with pembrolizumab. Kind of a very strange combination, you might think, if you're from Bristol. In any event, look at the data, look at the difference. Here we are at 24 months, here we are at 24 months, massively improved overall survival. And this is the kind of thing that checkpoint inhibition can accomplish, much like pancreatic carcinoma. Immune checkpoint inhibitors approved by the FDA as of this year include many diseases that they encompass: head and neck squamous cells, classical Hodgkin's lymphoma, hepatocellular carcinomas, gastric and GE junction cancers, melanoma, Merkel cell, cutaneous squamous cells, primary mediastinal B-cell lymphomas, non-small cell lung cancer, small cell lung cancer, triple-negative breast cancers, renal cell carcinomas, urothelial carcinomas, MSI-high colorectal cancer, and cervical cancers. This indication is remarkable. This is not even an organ. This is just if any solid tumor has mismatch repair deficiency, it is subject to being treated with a PD-1 inhibitor. This is a revolutionary indication because normally the FDA has approved drugs for a specific organ of origin: breast cancer, bladder cancer, lung cancer. This goes beyond all that. So now we have immune checkpoint inhibitors approved as monotherapy, as combination therapy with each other, and also with chemotherapy. We began the story by treating stage 4 cancers, particularly tough ones like melanoma and lung cancer, as third and fourth line treatments. The efficacy was so dominating that they quickly moved up into first line for metastatic disease, stage 4. Then they moved into stage 3 disease, which is basically adjuvant therapy for melanoma and for lung cancer. And now studies are underway that will probably, in a very few months, produce approvals for drugs in the neoadjuvant setting, meaning at the time of diagnosis, even before any surgery would be done. Simply diagnose the tumor, give the drug, shrink it, see whether it's still there, and if it is, remove what's left. And that's a remarkable progression in a very short period of time. This slide is too busy. I will just summarize it quickly by saying these are the FDA-approved immune checkpoint inhibitors targeting PD-1, cemiplimab and nivolumab on this particular slide. But look at all the indications: metastatic squamous cell carcinoma, advanced renal cell, melanoma, small cell, non-small cell, renal cell, Hodgkin's lymphoma. This is one drug indicated for all of these indications, and even hepatocellular carcinoma. And the cemiplimab, which is a fairly new drug, has got relatively limited indications. This drug was approved in December of 2014. This drug, pembrolizumab, which is also a PD-1 inhibitor, was approved in September of that same year. So it had a little bit of an advance on the nivolumab. And so look at all the indications for this. It's unbelievable how many different tumor types can get this. I'm merely showing this to you because our interest is talking about toxicity, but this is all the applications. And so if it's used this prevalently, it means there's a lot of exposure to potential toxicity. Targeting PD-L1 and CTLA-4 are atezolizumab, avelumab, durvalumab, and then CTLA-4 is ipilimumab. Once again, quite a few indications, urothelial carcinomas, Merkel cell, and then MMR deficient cells as well, all the way through. If you look at the indications for these and you attempt to determine at what point in the natural history of a patient's disease are they actually getting these are the drugs: nivolumab, pembrolizumab, atezolizumab, durvalumab, avelumab. This is spelled wrong. It should be Libtayo, but this is cemiplimab. But these are mainly stage 4 disease processes, okay? Stage 4, generally speaking. In melanoma, however, pembrolizumab and ipilimumab, as well as nivolumab, have indications for adjuvant therapy after resection for node-positive disease. And then durvalumab has an indication in stage 3 disease after platinum chemotherapy and radiation to preserve the response as described in the Pacific trial. Here's an example of a patient, 72-year-old man, who had symptomatic progression after biochemotherapy for melanoma. And this means the use of, in those days, biochemotherapy was temozolomide or DTIC combined with IL-2 or interferon. He then got high-dose IL-2, and then he got ipilimumab, and then he progressed. And this is where he was in April of 2012 with big tumor in the lung with a pleural effusion and a large hepatic metastasis, obviously progressive advanced metastatic melanoma. He gets pembrolizumab, PD-1 blocker. A year later, he's in complete remission. This is way down the line. This is not an unusual story. Adverse events, that's what we came together tonight to discuss, really, but we had to look at the mechanism of action in order to really understand this. The immune checkpoint inhibitors have introduced a tremendous transformative group of durable responses in many malignancies, but because it can activate immune cells in non-tumor components, meaning self-tissue, it can then mimic autoimmune conditions. Michael Posto in the New England Journal last year offered some potential mechanisms of the development of the adverse events related to immune checkpoint inhibition. So here's a tumor cell schematically with T cells attached to it based on their recognition of neoantigens. So in one situation, you may have a myocardial cell that shares antigens with the tumor, and so therefore it gets involved in the friendly fire of the immune response. Or if you have a pre-existing underlying autoimmune disorder like thyroiditis with antithyroid antibodies, and you turn the immune system on, pull the brakes off, and reduce the Tregs, then you're basically allowing for that autoimmune process to flourish. And so that's another way toxicities can come about. You also are turning on the release of cytokines, for instance, inflammatory cytokines, which can irritate the bowel mucosa and produce colitis and diarrhea. And then you can have a mechanism by which, for instance, the therapeutic drug itself can bind with surface molecules of the target, and then as a result of that, for instance, in the pituitary, which contains CTLA4, once the therapeutic antibody binds to it, it can then fix complement. Complement can then release cytokines, C3a, 4a, C5a, and also the dreaded membrane attack complex. And the membrane attack complex drills holes into these cells and destroys them. So the pituitary can be a target based on that mechanism. And that's one of the toxicities that ipilimumab has that's a little bit more commonly seen than in the PD-1, PD-L1 checkpoints. So now we have a new spectrum of adverse events. It's not just low blood counts. It's not just, GI tract stomatitis. It's a systemic group of autoimmune disorders now that we have to deal with and be able to recognize and understand how they play a role in what we do, because we can use them to our benefit. So you can have hypophysitis, inflammation of the pituitary, Zika, dry mouth, hypothyroidism, hepatitis, pancreatitis, autoimmune diabetes mellitus, rashes, very common, arthralgias, ocular inflammation, pneumonitis, adrenal insufficiency, and of course, colitis. Patients can have skin involvement, very commonly, colitis, hypophysitis, meningitis, pneumonitis. And these are all autoimmune in origin, generally speaking. This is a study that was offered by Michaud in the European Journal of Cancer in 2016, looking at both low-grade toxicities as well as high-grade toxicities seen with immune checkpoint inhibitor monotherapy, okay? In other words, just CTLA-4, just PD-1, just PD-L1. And so what they found is with the low-grade toxicities, the CTLA-4 drug, ipilimumab, appeared to have more toxicity. And its effect is much more proximal in the immune system, and so it's more capable of actually doing that. So skin toxicity, low grade, is almost 40% of the patients, GI, pulmonary, and so forth, endocrine. Whereas the PD-1 blockers, Nivo and Pembro, a little bit less in general, but still skin, GI tract, arthralgias. And the PD-L1, probably the least in terms of the mild toxicities. Now, in terms of the serious toxicities that will lead you to either discontinue the drug or put the patient in the hospital or produce a morbid condition that could be permanent, are thankfully much less common, single-digit incidents in this study for the PD-1 and PD-L1, although the ipilimumab still has the capability of producing GI toxicity that's significant and endocrine toxicity that's also significant. One of the reasons ipilimumab is generally only given as 4 doses and it's not maintained because of that toxicity, although there are currently some studies ongoing using very low doses and using it as maintenance therapy. We'll see how those turn out. Now, Dwight Owen in ESMO last year had a retrospective review of the overall incidence of colitis at Ohio State, and they found it to be about 6%, pneumonitis about 3.8%. But what was interesting is the types of toxicities were a little bit different depending on the actual tumor that they were attacking. For instance, colitis was significantly more common in melanoma, and pneumonitis was significantly more common in non-small cell lung cancer. Another sort of quirk of this type of therapy that we're only now beginning to understand how complex it really is. But does it work? Yes. This is the survival benefit that can be seen with combination immune checkpoint inhibition. This is the phase 3 Checkmate 67 study using nivolumab and ipilimumab in previously untreated melanoma. And you're looking at 2 years out here, and look at these curves. I mean, these patients used to, you remember the curve we saw in the beginning? It goes something like this. Well, now ipilimumab alone looks like it's tailing out here at 36 months. And nivolumab plus ipilimumab has the best curve. And it also looks like they're tailing off. But the problem is that when you combined these agents, you also increase the grade 3 and 4 treatment-related adverse events. So that the combination, 59% of the patients had grade 3 or 4 toxicity, which is quite serious. And only 21% for the Nivo alone, and 28% for the IPI alone. This data was just updated last month in the New England Journal of Medicine by James Larkin, and you can see that the data is holding up. Here's the survival, and here we were before. Look, we're still having, especially with the combination, this is virtually a flat line going out here. This is 5 years. Unbelievable. And this is progression-free survival, which is, of course, lower because these patients can still be alive and then be recaptured with other therapies. But the data is just totally remarkable. Now, Jeff Weber, who, by the way, visited us on Saturday and spoke at our fall cancer conference, produced this study, which was looking at any grade toxicity of treatment-related adverse events over time to see what the time course of development was. It looks as though most of the toxicities, skin, GI, endocrine, hepatic, pulmonary, and renal, appear to happen in the first 4 months, and then less so in the next 4 months. But look at this. Even out this far, over a year, you're still seeing patients with endocrine toxicities and hepatic toxicities. Patients, even well after the drug has been started, can develop these toxicities. In many cases, they can develop these toxicities well after the drug has been stopped, and we're going to look at a case that demonstrates that. Pseudo and the JCO a couple years ago looked at a retrospective review of about 450 patients with advanced melanoma that was treated with the combination. And what they were looking at is the onset of severe toxicities with the combination in melanoma. And they were looking at mediums. So skin had basically a 3-week median. But look at the confidence interval. You can never be sure you're out of the woods with a confidence interval that big. And GI, 7 weeks, 8 weeks for hepatic, 11, et cetera, down to renal, which was 16, with smaller confidence interval changes. But there is a kind of a timeline for these, but boy, it's so individual from case to case that you just have to be aware of it constantly, even after patients have finished a course of therapy or have discontinued a course of therapy because of toxicity. You might think that, well, if I discontinue the drug because of side effects, am I compromising the patient's outcome? And the answer to that is probably not. Here is Shadendorf in the JCO a couple years ago looking at the progression-free survival of patients with melanoma who either discontinued because of toxicities or did not discontinue. And these lines are very close. In fact, the median is only about 2 months difference here. But when it comes to overall survival, it actually looks like the patients who discontinued are actually doing better than the patients who continued. And there's a reason for that. And we'll talk about that in a little bit. The immune-related adverse events can occur after the discontinuation of the ICIs, as I mentioned. So here's a retrospective review of 64 patients reported by Shishtari and the JAMA Oncology last year. They took these 64 patients with advanced unresectable melanoma who were treated with a combination at, I think it was Sloan Kettering. It was a 1-year duration. And out of the 64, there were 31 patients who had to stop early because of toxicity. And actually 13% of those patients experienced clinically significant new adverse events greater than 4 months after discontinuing. Once again, underscoring that there's a little bit of variability and you simply have to be aware of it and watching these patients constantly. The unique aspects of immuno-oncology are this. Your responses can either be straight line, like old-fashioned chemotherapy, where the tumor just shrinks when you apply the cytotoxic agent, or you can have the tumor just stay in place because it's in a détente, or you can have early progression followed by shrinkage. And this is called pseudo-progression, which is something we never saw before, but we're now seeing with immunotherapy. And the mechanism we think by which it happens is the tumor cells are here, they get invaded by all of these reactive immune cells and create either an image on X-ray that didn't exist before because it was too tiny to be filmed, or show the enlargement of signal metastases that are being watched and measured because there's this initial skirmish going on between the tumor and the immune system that's filling out the space in the tissue. An example of this is this patient with malignant melanoma. This is a screening picture of a chest wall tumor process, very advanced, a lot of necrosis. This is 12 weeks after getting ipilimumab, and it looks actually worse. It's like it's progressing. But if you waited just 2 more weeks, it starts shrinking. And then 2 more weeks after that, and by 2 years, it's completely gone. Again, immunotherapy, and it's pseudoprogression and then response. Pseudoprogression only occurs about 10% of the patients, by the way. But still, it's a phenomenon. It can make you go down the wrong avenue if you misinterpret what it means. So you have to be very patient with immune therapy to be sure you're assessing it properly. Now, how do we identify, assess, and manage these immune-related adverse events? Majzoub in Emergency Medicine this year produced a retrospective review of about 628 patients who were on immune checkpoint inhibitors visiting the emergency room at MD Anderson in a 5-year span between 2011 and 2016. And there were 1,000 visits. 25% of these were related to the adverse events of the immune checkpoint inhibitors. And about 82% of these ended up being admitted to the hospital. If you look at the side effects that produce the admissions, you see diarrhea, particularly with ipilimumab, a little bit less so with Nivo, a little bit less so with Pembro, but when you combine them, it's even more than Ipi alone. Colitis, you can see the numbers, pneumonitis, dermatitis, hypophysitis or pituitary inflammation. Hepatitis, perhaps with nivolumab, and then smaller numbers with thyroiditis, pancreatitis, and adrenalitis, and very uncommon with nephritis, hematologic toxicities, myocarditis, vasculitis, or ocular changes. So how do they present? Well, the dermatologic picture can be a maculopapular rash. It can be virtually anything. It can be blisters, it can be eczema, it can be lichenoids, psoriaform. The diarrhea and colitis can be diarrhea alone, or if there's abdominal pain, it might signal colitis because of inflammation of the GI tract. There can be weight loss and dehydration. Hepatic is often picked up with routine blood tests, pancreatic similarly with amylase and lipase testing, but also severe abdominal and back pain, depression, weight loss, endocrine, headaches, visual changes, altered consciousness, deranged electrolytes, particularly when the adrenal gets involved, mood changes. And if you miss hypophysitis, you may see the most extreme toxicity of hypophysitis, and that is when the pituitary swells inside the cella turcica of the brain. What it does is it knocks out the nerves that pick up the lateral fields in your vision. So you can end up with what's called a bitemporal hemianopsia, where you've lost the vision of each one of your fields on the outer part. This can happen if hypophysitis isn't recognized and treated when it can be. Pneumonitis, these are all typically found the typical way you would find these things. Neurologic, fluctuating muscle weakness, mostly proximal, then distal, absent DTRs, behavioral changes, weakness, focal toxicities. Cardiovascular, these patients can get chest pain. We're going to look at a case where the cardiovascular toxicity is very dramatic, and musculoskeletal, particularly arthralgias and arthritis. Some rare immune-related toxicities, the induction of lupus, inflammatory enteric neuropathies, myocardial fibrosis, acquired hemophilia A, autoimmune polymyositis, Guillain-Barré syndrome, type 1 diabetes, multiple sclerosis, myasthenia gravis, on and on. Anything that has an autoimmune component can be induced by these drugs. So any new symptom should prompt serious consideration as a potential side effect of the treatment. Patients should carry a wallet card that defines what their disease is, what their treatment is, and who their providers are, so that when they travel or in the middle of the night when they're in the emergency room at Sentara Lee Memorial Hospital, they will then be able to present their card, and the first question you as the emergency room clinician should ask is, have you ever received an immune checkpoint inhibitor? Because everybody does now. And do you have an immunotherapy wallet card? And do you have an underlying autoimmune condition, which could be exacerbated by this? Because in the real world, we're treating patients with autoimmune conditions, whereas in the clinical trials that were the pivotal studies that gained the approval for these drugs, all patients with autoimmune illnesses were excluded in order to make it pure and simple. What is the time course for reversibility of the side effects with immunosuppression? Well, the rash and the diarrhea and the liver toxicity all appear to get better with different degrees of rapidity, but you can see that hypophysitis is a little bit different. This can be permanent, And it's because of the location of the pituitary. If the pituitary is squeezed by the sella, loses its vascular supply, becomes ischemic and fibrotic, it no longer will function, and these patients will require lifelong replacement therapy. You might think, well, if I use steroids to moderate these toxicities, am I not interfering with the effect of the drug? Am I not abrogating the drug? Am I not basically preventing it from doing its job or reversing what it's done? And the answer to that is no. And here's Jed Walchuk's lab producing this data. This is the effects of steroids on survival. This is a retrospective analysis of almost 300 melanoma patients treated with full-dose ipilimumab, 35% of whom required immunosuppression for immune-related adverse events. So now you're looking at overall survival. The yellow curve is patients that derived any toxicity at all. And so you can see all the dots on that curve because a lot of them did. And patients who did not have toxicity, and these curves are very close to each other. They are not significantly different by p-testing. And here is the overall survival if they got steroids or did not get steroids, and they're superimposable. So you can treat the toxicity with steroids, but you do not abrogate the survival effect. And all you have to do is produce that toxicity, and that's the beginning of a response. But you have to control it because it can get out of hand and actually kill people too. So time to treatment failure, you can see actually the patients that had toxicity actually seem to do a little bit better on the progression-free survival. This is a very complex thing. How do you simplify it for yourself in clinical practice? Here's a group, Clinical Care Options Oncology, which has produced more or less like a graphical user interface for the NCCN guidelines. So NCCN guidelines are our Bible to follow for indications as well as management. This tries to simplify it. For instance, this patient has a gastrointestinal toxicity. So you click GI, hepatic, or pancreatic. The next thing it asks you is, what is it? Well, in this particular case, this theoretical case, it's a grade 1 elevation of the transaminases, but a bilirubin of greater than 1.5 times the upper limit of normal in the absence of a Gilbert syndrome. This immediately tells you what the NCCN would tell you, which is this. So we go back to the simplified one, permanently discontinue the immunotherapy, initiate high-dose steroids, monitor the patient in the house, get a hepatology consultation, and if there's no improvement after 3 days, consider adding mycophenolate. And when the liver enzyme showed sustained improvement, reverting to grade 1 or less, then and only then, and if that takes 3, 4, 5 weeks, you have to continue full dose. It's only after you've gotten the toxicity to grade 1 or less that you can then begin to taper the steroids. And they should be tapered very slowly over a period of a month. You're going to lose nothing in this process because if you've gotten that toxicity, you're already thresholding. There's an article in the, I think it's the October 20th, JCO, Journal of Clinical Oncology. Julie Bramer, who has spoken to us last year at our fall conference, and Evan Lipson, who spoke to us a few years ago on melanoma, have put together a beautiful article on re-challenge after stopping immune checkpoint inhibitors for toxicity. And one of the things that she made a point of telling us about was that patients who have a response to immunotherapy have an approximate 4-fold increased incidence of immune adverse events as opposed to people who do not respond. So it tells you get that toxicity and you're already in a new category of potential responder, and then control the toxicity. This basically is a simplification of this. This is the NCCN guideline. And here you are, our patient, grade 1 transaminitis with greater than 1.5 times the upper limit of normal bilirubin. So now we have to see this. Oh, by the way, there's a caveat here. If they don't improve with steroids, you can add mycophenolate, CellCept, but infliximab, the anti-TNF agent, should not be used for hepatitis, even though it would be effective for that. The problem with that is that infliximab has its own hepatic toxicity and can actually lead to hepatic failure and the need for hepatic transplant or even death. So here it is, the grade 1 transaminitis. You rule out other etiologies, you get a GI consultation, you limit hepatotoxic drugs, including Tylenol and alcohol. You permanently discontinue the immunotherapy because the bilirubin is already out of the woods. You initiate steroids at really high doses. You watch the patient in the house. You have the hepatologist see the patient as well. And if they don't respond after 3 days, you add more immunosuppression, but you should not use infliximab if you have to go further. You can use vedolizumab if you want, Entyvio, an anti-integrin monoclonal antibody. So here's a case. This is a patient with Merkel cell carcinoma and diarrhea. A 65-year-old woman presents to the ER, up to 8 loose stools a day and abdominal pain for the last few days. Her husband says that she was diagnosed with cancer 10 months ago. And when she was asked, she provides a wallet card from her oncologist stating that she's getting evaluamab for metastatic Merkel. And she reports eating a salad at a restaurant a week ago, and since then the restaurant has reported a cyclospora outbreak related to their lettuce. But the stool sample she provided was negative for C. difficile, cyclospora, and other GI pathogens. She had colonoscopy and it showed severe colitis. Now, you can have diarrhea and you can have colitis, but they don't necessarily correlate one-to-one with each other. For instance, here's a patient who has no abnormalities on colonoscopy but has grade 2 diarrhea. Here's a patient with grade 2 diarrhea but has severe erosive and friable mucosa on colonoscopy. Here's a grade 3 diarrhea with normal colonoscopy and a grade 3 with lots of problems, including necrosis and ulceration. And here's a grade 1 diarrhea in a patient who has really very extreme colitis. Colonoscopy is important to recognize, since colitis is certainly a process that you have to control because of the possibility of sepsis and perforation. In this case, if it was grade 3, you would permanently discontinue ipilimumab, and you would discontinue temporarily a PD-1 agent if you're using them in combination, but consider resuming the PD-1 drug after resolution of toxicity. If it's grade 4, you're permanently discontinuing immunotherapy of any type and supportive care and so forth and so on. And that's mirrored in this NCCN panel. I won't go into it in detail, but suffice it to say that when these problems are brought up to you, you go to the NCCN guidelines and you can, in very excellent detail, review exactly where your patient stands, including how you define the grade, fewer than 4 bowel movements, 4 to 6, more than 6, know how to grade them in terms of moderate and severe, and then exactly what to do in terms of managing that patient. And if they are refractory to infliximab, you would consider Entyvio at this point. So the CCO uses these guidelines and tries to simplify it for you. And this is something you can do online very easily. Case number 2. This is a patient with melanoma and a rash, a 51-year-old man with unresectable melanoma presenting to the ER with a severe pruritic maculopapular rash with eruptions over his chest, back, and upper arms, reporting that the burning sensation kept him awake overnight and it was too painful for him to shower in the morning. He was vacationing with his family at a nearby beach and forgot to reapply his sunscreen in the afternoon. And when he was asked whether he had received immunotherapy, he reported that he received 2 doses of Nivo and Ipi through a clinical trial, but he stopped it 5 months ago because of diarrhea and colitis. This is his skin, which is a grade 3 maculopapular rash, meaning it's covering more than 30% of his integument. And here are the guidelines. We'll go straight to the NCCN. So here's your maculopapular rash and your mild, moderate, severe, defined as to what percentage of the body surface area it's covering. The milds get symptomatic treatment. The moderates get symptomatic treatment with the possibility of adding systemic steroids. And of course, severe and grade 4, which is life-threatening, have to get significant systemic immunosuppression, urgent dermatologic consultation, and consideration of inpatient care. This is pruritus, very similar to the skin rash. And you have your mild forms, which can be treated with mild agents and topical agents. And then the more severe pruritus may be requiring, in addition to holding immunotherapy, steroids or GABA agonists, or even neurokinin 1 antagonists, or even anti-IgE monoclonal antibodies. Bullous dermatitis, Stevens-Johnson syndrome is a separation of the dermis when it goes really severe and extensive, involving more than 30% of the body. It's considered a toxic epidermal necrolysis. This is a very severe toxicity, would require discontinuation permanently of immunotherapy, steroids, inpatient care, and of course, not only dermatology consultation, but ophthalmology and urology consultation because of the involvement of the mucosa of those organs. So here's a patient with skin rash and blistering. Here's a patient with digital necrosis, microvascular obstruction, and livedo reticularis, which basically is obstructed capillaries, and then the venous circulation beyond that just puddles because it's not being pumped. And so it looks like a corpse, essentially. Case number 3 is a patient with pulmonary metastatic melanoma and acute dyspnea, an 82-year-old man presenting to the ER with dyspnea and cough, sputum production. His daughter reports that he is getting Pembro for metastatic melanoma, diagnosed 2 years ago. And his x-ray shows rather extensive disease, bilateral disease. Nadeau from Sloan Kettering did a beautiful article in 2017 looking at about 900 patients from their institution getting mono and dual immune checkpoint inhibitor therapy. And what he sought to do is to try to characterize what the pneumonitis looks like in these patients. And he found various patterns: a cryptogenic organizing type of pneumonitis, a ground glass appearance to it, interstitial pattern, a hypersensitivity pattern with this tree and bud nodularity, and then one that didn't fit any category. And not only that, one of the very strange things about that study is that the onset of pneumonitis could occur as early as 9 days into therapy or as late as 19 months after the start of therapy. So once again, you got to keep thinking about these things as you go. The guidelines. Here we are, pneumonitis, severe pneumonitis is what we have. And so this is permanent discontinuation of immunotherapy, inpatient care, working it up for infectious either etiology or superinfection on top of toxicity. You want a pulmonary consult. Bronchoscopy should be done, particularly when you're trying to make a decision about whether to continue a therapy that's life-saving or not. Empirical antibiotics, steroids, and if no improvement with steroids within 48 hours, infliximab or mycophenolate, or even IVIG, which can basically jam the immune system and get at least the phagocytes off the normal tissue and get them to stop damaging normal tissue. And also, actually, IVIG can cause a feedback inhibition of antibody formation to some degree. Here's case number 4, a patient with metastatic melanoma and a leg fracture. 52-year-old man fell in the bathroom, fractured his fibula. His partner reports that he has melanoma and had recurrent metastatic disease within the past year, started Nevo 3 months ago. 1 month ago, he was feeling tired, but he was able to work. But 9 days ago, he starts getting very fatigued, dizzy, and dehydrated. Labs are done. His sodium is low. His TSH level is normal. His free T4 is kind of borderline. We'll say low normal, even though it's slightly below that. His AM cortisol extremely low. That's when it should be high. And his ACTH level is very high. So his ACTH is high, telling you that his pituitary is working, but his adrenal gland is not. So primary adrenal insufficiency, this gets treated a little bit differently than the others because now you can replace hormones for adrenal insufficiency. You don't necessarily need to use systemic steroids unless there's an acute hemodynamic crisis. So this is treated somewhat differently, as is hypothyroidism, which can be simply treated with replacement, but not necessarily with systemic steroids. So the patient gets his first dose of hydrocortisone, 50 milligrams IV, which is not a huge dose, and then goes on replacement doses only, not stress doses. He has 1 dose of Nevo held. He's instructed on how to be very careful about stress and hydrocortisone use. All of his symptoms resolve rapidly, and he gets put back on nivolumab, and 9 months after being on immunotherapy, the patient's cancer is continuing to show regression. So myocarditis is a relatively rare but definite complication of this disease, particularly seen when you have combination checkpoint blockade. If somebody's going to go on combination checkpoints like Ipi and Nivo or Ipi and Pembro, then you need to get baseline electrocardiograms, troponin levels, BNP levels, and a strain echocardiogram to know where your patient's at the very start. If they have any myalgias, you might even want to consider some myositis antibody panels. But grade 1, which is basically laboratory changes, including echo abnormalities, you will hold the immunotherapy, monitor the EKG very carefully, and make sure the cardiologist is involved. And if it resolves to grade 0, you can resume the immunotherapy. You might consider cardiac MR. If it's grade 2, which means symptomatic with moderate exertion, the patient needs to be hospitalized. They need to be followed serially by EKG and echo. They need to be on steroids, and the cardiologist needs to be involved. If you can get it to improve, then you can perhaps reintroduce the immunotherapy. But if it doesn't, you may have to go to secondary forms of immunosuppression. This is an interesting and sad case reported by Johnson and his associates in 2016 in the New England Journal. This is a 65-year-old lady with advanced malignant melanoma who is 12 days out from starting ipilimumab and nivolumab, combination therapy. At that point, she presents with chest pain, shortness of breath, anxiety, and fatigue. She's seen, and an electrocardiogram shows an intraventricular dissociation, leading ultimately to ventricular tachycardia. This patient dies. She has an autopsy done. Her myocardium is infiltrated with lymphocytes, autoimmune, targeting the myocardium. When they're stained, they're found to be CD3 positive T cells and CD4 positive T cells, which are basically those effector organs towards an antigen or a target. And interestingly, when they biopsied her esophagus, they found that the striated muscle was infiltrated, but the smooth muscle of the esophagus was uninvolved. So this is striated muscle and cardiac muscle, but not smooth muscle. And this is a rare toxicity, particularly for patients that have combined therapy. So you want to correctly identify your patients who are receiving immunotherapy and characterize their symptoms, triage these symptoms, jump on these symptoms, even if it requires hospitalization the same day, and establish institutional standards of practice for the management of these. And you can begin to use some of these tools, these online tools, to standardize your own practice. And of course, not only the providers and staff, but also the patient should all be on the same page with regard to what this treatment can accomplish, but also what it can do in terms of toxicity. Cancer Care of Ontario has also produced a nice tool that you can get online. And I'm not going to go through this in detail, except to say, and what I'll do is show you the various different forms of toxicities and what you do. And we're going to look at one of these. The renal toxicities. Let's just look at this last one. So what they do is they describe the toxicity and grade it and tell you how to grade it. So you can know exactly what you have to do with regard to the doctors you need to get involved in the referral process, the amount and type of steroids and the administration and tapering schedule that you should do, and then the supportive care that you will have to do all the way down to hemodialysis or even secondary immunosuppression. And then what you do with the immunotherapy itself. So these are tools that you can use. And this is basically the last slide. And just to summarize, the guidelines that we have for immunotherapy toxicities, we use NCCN very heavily. ASCO guidelines by Julie Bramer were published in 2018, and she continues to write on this subject and is a tremendous source of information. Clinical Care Options has the online tool, which is like a graphical user interface for the NCCN, Cancer Care Ontario, and then the various pharma, including BMS, who are with us tonight, have produced algorithms for managing the toxicities so that your patients can get the best outcome. So that is all I will mention about this, but I would be happy to field questions. Any questions? Nikki.
So you brought up the issue of patients are excluded from the clinical trials if they had autoimmune disease,
Yes.
but they walk in the office and they have cancer.
Yes.
How do you approach that?
That is a topic that is of great interest, actually. And Laura Kennedy published a beautiful article in the Journal of the NCCN in June outlining this very issue. And I would recommend anyone that's involved in this therapy to read that article. What it was basically a compilation of 8 different case study series of patients with all types of autoimmune processes: rheumatoid arthritis, lupus, myasthenia gravis, Guillain-Barré syndrome, thyroiditis, you name it, anything that was autoimmune in origin. And what they found in terms of takeaways was several things. 1, you definitely can treat these patients. 2, don't use ipilimumab. It produces way too much toxicity in these patients, particularly on the endocrine side. The PD-1 and PD-L1 drugs can be used much more safely in this situation. Secondly, you involve a multidisciplinary team. The rheumatologist should be part of it, the oncologist, maybe the cardiologist, depends on what other comorbidities the patient has. She pointed out that in this process of treating patients with autoimmune disorders, if you're going to get results, you have to have some self-recognition of the immune system. In other words, you can't have just blank immune self-tolerance, because if you do, the drugs ain't going to work. If they know normal tissue and are never going to touch it, that means they're so diluted, they're not really going to kill the tumor either. So you have to risk some toxicity to get results. Now, one other area that's important is the question of, so you stop the drug and you feel like you need to restart it at some point when you get the toxicities reduced. This is a new area of research, and a lot is being written on it right now, and there's no hard and fast rules on it. But there are a few things that you can consider.
Re-challenge. Are you talking about re-challenge?
Re-challenge, yes. We've moved away from you can definitely treat patients with autoimmune disorders. I might just make 1 or 2 other comments about that. When it comes to certain autoimmune conditions like psoriasis or thyroiditis or skin problems, other skin problems, or even rheumatoid arthritis, when you have those kinds of diseases that when they exacerbate, they're not going to produce a mortal condition, they're not likely to cause death, then you can be a little bit freer with your treatments in those patients. But when you have somebody that has a very critical autoimmune illness like Guillain-Barré or myasthenia gravis or multiple sclerosis, you can't risk immunotherapy in those patients unless you do it under very controlled circumstances, because you can lead to a permanent deficit in those patients because neurological tissue just doesn't regenerate very well. And if you push a patient over the edge who's already having breathing difficulties and is now hooked to a ventilator the rest of their life because you were attempting to control a disease process, that's a judgment call that has to be made with not only the multidisciplinary team, but also the patient and their family have to be part of the decision. Now, the other thing I think you're interested also in is, what do you do after you stop the drugs? Can you restart them? And if so, what are the caveats with that? There's a lot written on that now, and the current issue of the JCO has a beautiful series of articles on this very subject. And Julie Bramer and Evan Lipson have written an article on, and they've entitled it, The Challenge of Re-Challenge. Okay? So what is it that you have to think about? And what she and he pointed out was that you have to risk something. You have to have some toxicity, because toxicity spells response. They usually run hand in hand. We used to think, oh boy, the toxicity is simply going to interfere with me giving the drug the rest of the patient's life, and I'm going to compromise their outcome. But that's not the case. Once you get this process started, you don't necessarily have to keep throwing fuel on the fire, because that process is almost self-generating. If you've treated a patient with combination therapy, the advisability of retreatment is not to produce a combination treatment going forward, but to choose a single agent. So let's say a melanoma patient has an unacceptable degree of toxicity, a grade 3 pneumonitis. You treat that. Put the patient on oxygen, hospitalize, remove the drug, steroids, if necessary, mycophenolate, whatever. Get them down to a grade 1 so that now they're feeling normal. At that point, if you reintroduce the combination, you're likely to produce the toxicity again, and maybe even worse, and possibly risk death. So then you have the option in that setting to use a single agent. And at that point, you might choose a PD-1 or a PD-L1 inhibitor, which has much less potential to produce the toxic side effect that got the drug stopped in the first place. So re-challenge is something that we're studying now, and it's being looked at and written on, and I think much more experience is being gathered as we go along.
Given the severity of the side effects and what seems like a pretty high incidence of side effects, I've heard you talk about various specialties to get involved. What are your thoughts on getting palliative medicine or supportive medicine involved at initiation of such therapies?
Some of these patients are already involved with palliative care when they're approached with these drugs, and so that team is already involved. But certainly with some of these toxicities, which many of the docs and other clinicians are really beginning to grapple with themselves, like managing these exquisite endocrine abnormalities, or a pulmonary cripple, or a patient with class 3 heart failure who needs rehab and needs to be managed carefully. Those patients need supportive care. And whether it's palliative care or it's those divisions of supportive care within the different disciplines, I think is always good to have if you can accomplish it. You certainly would be involving palliative care if the patients have irreversible toxicities, because at that point they're probably going to die, and palliative care would be very important to be involved at that point.
I'm from Denver, and I know there palliative medicine was more involved with symptom management rather than just patients who were dying. So I hope that this agent embraces that going forward. I think that would be a benefit to patients.
It would be.
Yeah.
No, you're right. I'll tell you one area where we really need that kind of involvement is in pain management, especially opioid use and things like that. There needs to be a dispassionate, uninvolved manager of that can interact with patients and keep them on a straight track. So you're absolutely right. Yes.
It's really interesting that some patients that have had the immunotherapy stop due to adverse events and then did well over the long term compared to people who continued the therapy, maybe a little better. Is there sort of a process of looking at what is the endpoint or duration of treatment that's optimal, and does this fall into the realm of personalized medicine? Or are there markers so you can look at immunologic markers?
Great questions. Yeah, great questions. The clinical trials were all designed with about a 2-year maximum exposure to the immunotherapy. We just heard Jeffrey Weber talk about this very issue, who came to us on Saturday at our annual fall educational conference. And what he said is that when patients go into remission and you've controlled their toxicity and they're either off the drug because of toxicity has removed it, or they've reached a complete remission and you don't see the need for continue, you can stop the drug. No one knows if 2 years is really necessary. I know of several patients who have had a year of therapy and have stopped it either because they're in remission or they've had toxicities that have limited further use of the drug, and they continue in remission. Immunotherapy is a different animal than chemotherapy. Chemotherapy often is static. You have to continue using it. It's not curative. It simply keeps the lid on it. This is quite different. And one of the forms of immunotherapy that really is different is CAR T therapy. I mean, that's basically a kind of a lifelong, ongoing assault on cancer that, you've turned those cells on, so that's their purpose. They're going to constantly go after that cancer, wherever it is. So the answer is we don't really have a duration of exposure like we did with the old chemo. We would do, 4 cycles of whatever the chemotherapy was and then stop and observe, like in lung cancer, for instance. Now it's based on when does the toxicity start? How severe is it? How can you manage it? Did you get enough immunotherapy into at least maybe put that patient into a response category? Do you need to continue it? And it's an individualized question. In terms of markers, this is an area that's being investigated very thoroughly now, and it's just the beginning. But there are things that can tell you whether your patient's going to respond. For instance, a lung cancer patient who has a low galactin-3 level is more likely to respond to immunotherapy than one that doesn't. A patient who has a high tumor proportion score, staining on immunohistochemistry for the PD-L1, essentially, or a composite positivity score. Patients that have in their tumor biopsies high levels of infiltrating lymphocytes are more likely to respond because they're already demonstrating that their immune system is capable of beginning the attack. In terms of toxicity, one of the only things that we know of is, and it's a very weak parameter, but the neutrophil to lymphocyte ratio and the platelet to lymphocyte ratio can be predictive potentially of patients who are going to encounter toxicity. So the patients that have low ratios of those two things have a higher incidence of toxicity, but higher incidence of toxicity may spell a higher response chance too. But we're in the very beginning of trying to figure out all of these things. We know that in some skin disorders, skin toxicities, levels of IgE and the interleukin 6 and interleukin 10 can be predictive of response, but also may offer targets for control too. So that instead of using broad-based immunosuppression, you might be able to target your immunosuppression so that you're not exposing the entire body to steroids constantly, but treating specifically that process. So for instance, in those cases of skin disease that have a high level of IgE, you might want to use Xolair, the anti-IgG monoclonal antibody. Or you might want to use a specific anti-tumor necrosis factor antibody, such as infliximab.
Do you think innate immune function could play a role here in toxicity?
It does, because what happens is all of these things can activate complement at the very minimum. And when you activate complement, you're basically on a destruction track in the body. Because once the membrane attack complex is formed and once complement is activated and the cytokines are released, it just is basically pouring gasoline on the fire. Any other questions? Any answers?
Just thank you.
Yes, Cindy.
Well, my point was just to thank you. I think this was excellent. and certainly, you know, the toxicities associated with these, and to really help broaden the education, taken an incredibly complicated topic, and for me, really simplified it. So thank you for your time.
One of the best
Thank you.
teachers I ever had.
Absolutely.
Oh, thank you. Thank you. Thank you.